And now let's talk about managing maternal health, the inequities that exist for mothers of color, and ways to improve outcomes at both the community and clinical level. Please join me in welcoming our panel of experts. Patricia Laufman, ex officio board member of the American College of Nurse Midwives. Julie Allen, government relations consultant with the Preeclampsia Foundation. Dr. Allison Bryant, Vice Chair of Quality, Equity, and Safety with the OBGYN Department at Massachusetts General Hospital, and Dr. Lisa Olie, President of the American College of Obstetricians and Gynecologists. My colleague Rachel Rubine, healthcare reporter at The Hill, will lead this conversation. Rachel, over to you.
Hi, thanks everyone for being here. Special thanks to our panelists as well. We have just about 20 minutes, so I want to dive right in. Dr. Olie, more American women are dying of pregnancy-related complications. Can you tell us why this trend exists?
This is a multifaceted problem that will require a multifaceted solution. When we look at specific causes for maternal mortality, we have identified a number of important factors. Among those are the increasing number of women who have chronic medical conditions like high blood pressure, heart disease, and diabetes. We also have identified that there is a significant lack of access to care for many women to have those conditions optimized before they become pregnant. There are also a number of conditions like cardiac events or heart failure, like cardiomyopathy that you heard about earlier today, that are becoming more common causes. And we are working very hard to address those specific causes and gather additional information that we need to understand the preventability of these different complications or causes of maternal mortality and start to implement solutions.
How can they be prevented?
There are a number of different opportunities that we have. If we look at some of the most common causes of maternal mortality, like high blood pressure or bleeding at the time of a delivery, the American College of Obstetricians and Gynecologists, in partnership with a number of the organizations represented here today, have all been working on best practices, groups of best practices or safety bundles that have been developed by the Alliance for Innovation on Maternal Health. And by implementing those packages of best practices in hospitals and facilities, we have shown that implementation significantly reduces the number of women who have complications, morbidity, or who have maternal death. So there are a number of solutions that we can implement in facilities that reduce complications and other opportunities as well.
Dr. Bryant, can you chime in on what you're seeing in ways that this could be prevented?
Sure, absolutely. I think that one of the things that I worry the most about is that we spend so much money in this country on healthcare and yet relatively less on sort of social spending. And I think that the healthcare system needs to sort of own a little bit of that, is that we need to understand where women come from so that when we talk about women coming into pregnancy not prepared for pregnancy, either because they didn't want to be pregnant at that time or because their health status is not sort of optimized, that we need to do more in terms of learning where our women come from. So do they have issues of housing insecurity, transportation issues, childcare? Are they able to access the services that they're able to provide? I think that the safety bundles have been amazing in terms of how we care for women when we have them in front of us. I think we need to think about when the woman is not yet in front of us and how we engage them. And I was also very pleased to sort of work with the Alliance on Innovation in Maternal Health, which actually elevated racial and ethnic disparities to the level of hypertension and venous thromboembolic events as a safety threat to women. And so I think that really understanding that we can't have quality care unless we have equitable care is really quite important.
Mm-hmm. And you mentioned the racial disparities. Pat, I was wondering if you could chime in. It's no secret that there are racial disparities. According to CDC, the risk of pregnancy-related death is 3 to 4 times higher for African-American women. Can you talk to us about this?
Yeah,
how it can be fixed?
I think that's very important. I think the temptation is usually to ascribe difficulties that women have mainly to women who lack education. But I think when we look at women who, African-American women who have higher incomes, their pregnancy outcomes are not as well as white women who, say, for instance, do not have a high school diploma. Or if you look at African-American women who have higher incomes and live in wealthier neighborhoods, their pregnancy outcomes are not as good. So there's something else that is operating here that is irrespective of higher income and higher education, because higher education and higher income does not seem to be protective for African American women. And we actually began to see that back as early as 1992. There was a report that was actually published that said that African American women with a college education, their outcomes were not as good as a white woman with a high school diploma. And so that was observational, but absolutely no explanation. And I think now we know that there are other forces going on that actually impacts women, either whether you are poor or whether you have college education or whether you are wealthy. There are other factors. And I think to not recognize the effect that structural racism has on women as a whole, on African American women, and not only African American women, but children and their external families. So racial and ethnic disparities really has more to do with structural racism than anything else.
I'd love to hear from you and anyone else on the panel on, what you would want from the federal government or just any policy-wise, the state level, anything that could help.
Well, often we talk about not having access to care, and we know that women who are on Medicaid, they tend to, even though they have access to care through Medicaid, once they enter that system, they feel that the system is hostile. And so you don't want to expose yourself to a system that's not really going to work for you. So I think in terms of integration of other types of healthcare providers, so I'm representing the American College of Nurse Midwives, and I want to put a plug for the midwifery community, because we certainly know that if midwifery care is good enough for Kate, it's certainly good enough for everyone else. I mean, when you look at countries that are comparable to the United States, 50 to 75% of maternity health care is rendered by midwives. In the US, it's only about 10%, but yet still the outcomes in other countries are much, much better than ours. So I think we need to look at what the actual complement of that healthcare team should be. Recently, the American College of Obstetrics and Gynecology and ACNM, we've just developed this wonderful collaborative agreement that says midwives are independent practitioners, and we really need to be integrated more as part of that healthcare team. And so I think that would go a long way to improving pregnancy outcomes for women.
It has been a great opportunity to work with the American College of Nurse Midwives. One of the things that we have been doing together is strongly advocating for the legislation that Representative Herrera-Butler talked to all of you about this morning. This legislation can help us provide the foundation for high-quality data, for detailed reviews of maternal mortality at the state level, and the opportunity then to closely evaluate that information, identify those preventable opportunities that you talked about, and then implement local solutions that really help to address the local problems. And it, again, has been a pleasure to work with ACNM to advocate strongly for this legislation. And as Representative Herrera-Butler said this morning, I think we have a great chance of passing the legislation. So I hope that all of you in the audience today will be strong advocates to really help us establish the information that we need to truly understand this problem and put the best solutions into practice.
And Julie, when you're talking to lawmakers or staff, what are you advocating for? We obviously heard a lot about the bill that Dr. Ollier mentioned this morning.
Yes, thank you, and it's a pleasure to be here today. I would say that the consumer voice is critical to this process, ensuring that the patient is engaged and engaging with their health providers, telling them what they're experiencing, what they're going through, the circumstances that may not be present in the medical record of what they experience back home. And that voice also needs to come forward when we're talking to Capitol Hill and explaining exactly why this legislation is so critically important. I'm very pleased on behalf of the Preeclampsia Foundation that we've been able to secure a large number of patient advocacy groups to start speaking out more so and talking about how, as a step forward, we can start to really analyze and understand what's happening in states and communities so that we can derive solutions to actually implement change. And this isn't an effort where we're trying to dictate from Congress what needs to be done. There is so much that's unique to what's happening back home, and a perspective that needs to be shared from the patient side as well as the provider side about what challenges are being faced and why women are dying in this country.
And Dr. Oye, you serve as chair of the Texas Maternal Mortality and Morbidity Task Force. Can you tell us what you found, any recommendations that you guys have found in this task force?
Absolutely. In our first report that came out 2 years ago, we identified several important problems. One of those involved data. Another problem that we identified was inconsistent or lack of referrals to behavioral health specialists and lack of access to postpartum depression screening for many women. We also identified inconsistencies in death investigations, and I'm really happy to say that the Texas legislature in their last session addressed all of those by setting aside funding to improve the vital statistics register, by working with the state to develop training on death investigation, and by passing legislation to provide payment for postpartum depression screening within the Medicaid program at a child visit. So that was a great opportunity that women were taking advantage of for their children, that gave us also an opportunity to provide that behavioral health screening. So a great opportunity for those state-based reviews to understand the problems that were happening and then identify the appropriate solutions to put into place.
Dr. Bryant, can you talk about what you're seeing on the ground in terms of this?
Sure. I think that both in my work clinically as well as being on Massachusetts Maternal Mortality Review, I think we've seen similar issues, is that we oftentimes see excellent care provided to women during the courses of their pregnancy, and then this gap, and then women show up with either severe morbidity or mortality, remote postpartum. And I think that we all need to pay a little bit more attention to what happens to women in the first 1 or 2 years after their delivery. It's a sort of a time we tend to forget about women. And so if we sort of shift our thinking and not just think about women as sort of vessels for pregnancy and vessels for providing healthy babies, but really think about the value of women in our communities, our society, I think that we, in terms of our legislative priorities, in terms of the care that we provide to women, I think that we can truly do better by women.
Mm-hmm. And how do you think that change can be implemented, and what does that look like, that care in the first year, the second year?
Mm-hmm. So pleased to sort of see that ACOG sort of released this new postpartum task force and committee opinion on care for the women postpartum, sort of really suggesting that we really could do a lot better job looking at women sort of immediately postpartum and addressing those very acute needs, but also really tailing our care off to make sure that we are handing off women to primary care, handing off women to well woman care, caring for them through 3 months postpartum from the obstetrical side perhaps, and then really making sure that they are well packaged and well cared for in those periods of time. Programs like Healthy Start and a number of other community initiatives have really thought about how we can sort of provide better interconception care. So this real concept of caring for women throughout their life course with the needs that they have as they vary throughout the period of time.
Dr. Leah, can you talk a little bit about those recommendations from ACOG?
Absolutely. We are really emphasizing that immediate postpartum period, and ACOG has recommended that a woman have a visit with her maternity care provider within the first 3 weeks postpartum. In the past, we'd been recommending this type of early visit for women who had any type of complications, but we're making that recommendation now for all women. And we're really trying to encourage the postpartum period to be thought of more as a continuum rather than a single visit or event, but really integrate the care of the woman. As you so eloquently stated, it's really important to think of all of the care needs of a woman during this much longer period than, say, 6 weeks. And we're really trying to encourage a woman to be seen for her complete well-woman exam, if you will, no later than 12 weeks postpartum. So I think it's a really great time to emphasize that fourth trimester is one of the ways that we're talking about this incredibly important time in a woman's life, being sure that the focus is also on the mom and not just on her amazing, wonderful newborn.
Pat, did you want to chime in?
Yeah, I would actually like to congratulate my colleagues because they're beginning to sound like midwives. Because the midwifery model of care, we have actually been doing that, and we tend to provide less fragmented care, so we take care of women actually through the continuum. We continue to see them not only for their postpartum care, but we continue to see them for their well women care also. So we tend to know women before they get pregnant, during their pregnancy, after their pregnancy, and we continue that care forever. We tend to keep women on our panels for years and years and years. So we don't necessarily have that drop-off of women after that fourth trimester is over, because we keep them. So the care the midwifery model of care is much more complete and continuous.
We're going to take it over to questions in just a second. One more quick question for Dr. Bryant is, how can women in traditionally medically underserved areas get the care they need during pregnancy?
So I think it's important for us as the medical team to sort of engage women before their pregnancies and sort of make sure that women know where to present, when to present, how to call us, and understanding that not all women in all communities feel like the healthcare team is their advocates, and so really understanding that there is some mistrust in the communities. I was pleased to hear the conversation earlier about unconscious bias, and I think that we all as providers can own that. We have done unconscious bias training in our providers, and the AIM bundle calls for that as well, and I think if we really understand what our biases are, we'll be able to sort of better engage with our patients and have them come to us and also sort of reach out into them, into their communities.
We're going to open it up to audience Q&A.
Good morning. My name is Darlene Lawrence. I'm a family physician born and raised in Washington, D.C. I've been in practice more than 25 years, and about 25 years ago, I was a member of Secretary Donna Shalala's task force on infant mortality. And watching my patients and the community and the country develop, I guess, over the next 25 years has been really disappointing because of the news that has been coming out recently about the maternal mortality doubling over those 25 years. I treat patients in the DC area coming as far as way down in Virginia and way up in Maryland who will still come to see me in my practice. I now practice at a federally qualified healthcare center here in the district, Unity Healthcare. We take care of over 100,000 patients in our time, but we have been dealing with the crisis of having 2 safety net hospitals stop delivering and taking care of babies here in Washington, D.C. We have 3 university hospitals, but access to care is not equal to care. And so when there is implicit bias, when people understand what the gardener's tale that Dr. Camara Phyllis-Jones talks about so eloquently, you need to know that access to care is not equal to care. There is a level of distrust in this country and even in this educated city of Washington, D.C. that has not been addressed. And so when people don't trust the care that they are receiving, they're not going to go and get it. They're going to come into the emergency room in labor, in abruption, in preeclampsia, in full eclampsia. And I appreciate all of the work that everyone is doing, but we have got to understand where the implicit bias comes from in treating patients who have lived with and dealt with a history that has not treated them very well. In addition, I used to get up and speak on everything, and so I really wanted to speak to all 3 of the Congress representatives, but at this point, I had to talk because family medicine sees patients from the time they're born through the time that their grandmothers die. And we take care of them through the realm, and I deliver. It is a badge I used to wear. I deliver. So I take care of patients when they're trying to decide whether they're ever going to have sex or not, or whether they say, this is a horrible thing, I don't want to die like my sister did in labor. And then I take care of them when they're pregnant. And then I take care of them when they deliver and their babies, and I see their postpartum depression, and I address it at that point, and then I take care of them when they get pregnant 3 years from now, not 2, because I've helped them to decide that they should space their pregnancies. So we cannot leave out the 131,000 family physicians in the country who take care of their patients through the whole length of their lives. And I'm surprised that not one of us has been sitting up there on this panel today. So let's consider bias. And anyone who needs to see or look at that video is Dr. Camara Phyllis-Jones, A Gardener's Tale.
And we have just about a minute left. So Dr. Leah, do you mind responding to family physicians' role in this process?
It is a pleasure for me as ACOG president to partner closely with the American Academy of Family Physicians and to work with them on a number of issues. We have partnered specifically with the family physicians advocating for access to care and for better quality of care. And again, it is truly a pleasure. This problem, maternal mortality, is so important. This takes a huge team. It's going to take every single one of us, all of us in this room, working together to address all of the different facets of the problem and really find many different solutions that we all put into place and do our part to reduce the tragedy of maternal death in our country.
Well, thank you so much, everybody, for the great conversation.